Welcome. Let's talk about outpatient management for COPD patients. Firstly, in the first series, we'll talk about the general assessment and initial management, and in part 2, we'll talk about more about medications. So let's get started. Some of the initial complaints will be dyspnea in patients, fatigue, reduced exercise tolerance, and this information actually has to be teased out. A lot of patients will blame aging as a reason why they've slowed down, but try to compare them to their spouses if they're able to keep up with their spouses. Having the spouse during the appointment itself is extremely useful. Comparing them to people their age. If you are able to compare stair climbing as an ability to assess exercise tolerance, and if patients live in cities, for example, the amount of blocks that they have to walk before stopping to catch their breath as well is an important gauge of the exercise tolerance, and try to assess the decline over the last 6 to 12 months. Another one is cough as well as a symptom, and sputum production as well. So once you have that, the next thing to do is assess tobacco abuse history or exposure. So generally, you have a smoking history of more than 20 pack years, meaning about a pack a day for 20 years or half a pack a day for 40 years. So smoking history of more than 20 pack years will indicate the possibility of having COPD related to tobacco abuse. However, there's some evidence, at least, that in female patients, that this can occur at a much lower exposure dose. If they don't have or they don't fit into the 20 pack year history, at least, the other thing to consider is secondhand smoke, whether they as children or growing up, or even as an occupational exposure such as bartenders and so on. Occupational exposure such as factory workers and construction workers is an important history to elicit in these patients. I generally get baseline lab values or anything that I have within the last 6 to 12 months, and this would include a CBC or a basic metabolic panel. Now, if you do notice a bicarbonate level that's elevated above 28 in these patients, you may want to consider whether the patient has chronic respiratory failure secondary to their COPD. However, if they're on a diuretic like furosemide as well, contraction alkalosis is a consideration. Generally, I don't normally get an arterial blood gas as an outpatient. However, if there's any suspicion that the patient has chronic respiratory failure, I do tend to get that as well. A baseline chest x-ray, preferably 2-view if possible, and that's to assess for any signs of hyperinflation on the chest x-ray. For example, they'll indicate the patient may have underlying obstructive lung disease, but at least you can have something at baseline to compare it to. Comorbidities is the next thing. A lot of the comorbid conditions that need to be elicited is coronary artery disease would be the primary one, just because the symptoms of shortness of breath, reduced exercise tolerance, and fatigue could be confused for one and the other. So a coronary artery disease evaluation as well is important, or at least assessment to see whether they've been diagnosed or even assessed for that is important. The other comorbidities that may actually worsen their COPD is reflux, acid reflux. Now, the usual acid reflux component may not be, the acid component at least may not be relevant, as a lot of patients are on proton pump inhibitors, so they may not have the acid part of the reflux, but they do complain of increasing cough when they sit down at night or watching TV, when they're laying down in bed, increasing cough, or even tickling of their back of their throat when they wake up in the morning. So these are some of the signs to see whether reflux is a possible contributor to their worsening respiratory status. Another one is sinus complaints as well. Allergies or just chronic sinusitis is sometimes a precipitating factor, so evaluation of that. And another comorbid condition where we tend to get a mind-body relationship is depression. And nowadays as well, I advise screening for depression in COPD patients. You can use a pretty handy tool, the PHQ-9, which is a great depression assessment scale. The next thing is trying to find the level of obstruction in patients, or even diagnosing these patients. And the best way to do it is a spirometry. What we found is a lot of patients are being presumptively treated with a presumptive diagnosis of COPD without actually having any spirometries done. This may also sometimes lead you to treat the patient with an assumption they have COPD when they may have something else, coronary artery disease and so on. So you don't want to mistreat these patients. Spirometry readings have to be treated with caution, because at times, if you use the FEV1 over FVC ratio of less than 0.7, as your diagnosis or diagnostic criteria, you may overdiagnose elderly patients and you may underdiagnose young patients. The elderly patients, because as you get older, not only do your muscles tend to degenerate, but your respiratory muscles as well may tend to do that. So your ability to squeeze out air fast and efficiently may be minimized or reduced. Hence, you have a falsely reduced FEV1 FVC ratio. Hence, these patients' dyspnea may not be actually due to COPD, but they're falsely diagnosed as such. And in younger patients, just because of their respiratory muscle health, they're able to compensate for the obstruction by squeezing harder and trying to force that air out. And so that's why that was a recent, not so recent, but what's gaining in popularity is the lower limit of normal. The lower limit of normal stratifying each patient's risk of obstruction based on their height, sex, and age. And so this is a much more sensitive tool to pick up a patient for obstructive lung disease. Another thing to take note of as well is in spirometry, the readings are effort dependent. So if the patient doesn't really put in much effort or the respiratory therapist doesn't force the patient, you may have a falsely negative or a falsely positive result. So take note of that. Another note on spirometry readings as well, you don't need to get an annual spirometry if the patient's stable. If there's a decline that you've noticed and you need to figure out whether the decline is due to obstructive lung disease or another cause that may need further evaluation, then a repeat spirometry is warranted. The difference between a spirometry and a PFT, a spirometry will only really contain your FEV1 and FVC as your readings, while in PFTs, the PFT itself will include TLC and a DLCO or your diffusion capacity in addition to your FEV1 and your FVC. So that's a full PFT where you include everything else. Another note of caution as well in spirometry is up to about 10% of CT evidence of emphysema, or so on a CT chest, is not detected on a spirometry. Another clue is to look at the peak expiratory flow within 25 to 75%. This may help you gauge whether there's small airway obstructive disease. In most cases, the FEV1 FVC ratio tends to look at large to medium-sized airway disease. And however, if the COPD is still mild and still mainly localized to small airways, you may pick it up in the peak expiratory flow. And if this reading is reduced at least, or you see a concavity in the flow volume curve, for example, this concavity itself may mean obstruction. So these are some of the infallible abilities of spirometry. So take note of that. So just to recap, in spirometry, the lower limit of normal is better. It's effort dependent. A CT may pick up some changes or findings that before you can pick it up on the spirometry, or you can look at the PEF or peak expiratory flow, 25 to 75% as engaged for small airway disease. The next thing I tend to do is in patients that come in with signs and symptoms of COPD, and I'm pretty sure they have COPD, depending on the shortness of breath, I go ahead and when they do leave the office, I start them on albuterol, because I really don't want to have them wait and suffer and struggle to their spirometry reading before we figure out whether they do have COPD or not. So giving them albuterol inhaler may be something helpful. Now, if you find that the patient's not going to get their spirometry or PFT in the next few weeks, you may want to start them on presumptive therapy, especially if the strength of their history and smoking exposure is pretty reliable. I normally go to my go-to drug, which is tiotropium. Again, in patients, you want to always speak to them about side effects of medications. So you want to caution them if they have a history of glaucoma, or even in male patients, prostate hypertrophy as well. These are some of the most common complaints and common side effects that you need to take note of. So if the patient's not going to get their spirometry reading anytime soon because of transportation issues or ordering issues or insurance issues and so on, and I feel like their shortness of breath is significant impairment in their quality of life, I'll go ahead and start them on tiotropium in addition to PR and albuterol. However, if I think they're going to get the spirometry or PFT readings soon, albuterol should be sufficient. The next thing to do is assess or screening patients to see whether they qualify for the new USPTF or Preventive Task Force recommendation for screening low-dose chest CT. So screening low-dose chest CT is recommended now for patients with at least 30 years back year history of smoking, and they're current smokers, or they quit in the last 15 years. So 30 back year history, current smokers, or quit within the last 15 years, in addition to the fact that they're between the ages of 55 and 74 years old. You need to speak to them about, before they do undergo the CT, about the possibility of having false positives and so on. So then recommending the CT chest would be the next option in these patients. Assessment of a lot of COPD patients tends to be done subjectively. How do you feel? You feel better? You're coughing better? Is the coughing improved? Is the sputum improved? But usually using a more valid assessment scale. There are a few assessment scales out there. One is a COPD assessment test. The other one is a clinical COPD questionnaire. And the last one is the modified Medical Research Council questionnaire, which just generally uses dyspnea as a scale to gauge improvement. So these are some of the tests that you can repeat, or questionnaires that you can repeat on each visit to assess for changes, not only just using subjective measures. So these are some of the scales that are out there. The next thing to do is, in patients, especially if we find they're hypoxic for so on, is to assess them for long-term oxygen therapy. You can refer to how to assess for long-term oxygen therapy section that I've spoken about previously. If you have any further questions, the next section will talk about medications and starting them. Thank you.